yesterday I was told that I have to moderate this. Okay. So I don't know why medical oncologist is moderating this. Sir took a very entertaining session. Hopefully it is equally entertaining. So it's a tongue twister topic, multimodal management of multistation N2 NSCLC, non-oncogene addicted. Okay. So these are the, we know lung cancer is common and common cause of death as well, and we know most of the patients come in the loco-regionally advanced stage. TNM, yesterday I was looking at the staging, so they have defined N2 as metastasis in ipsilateral mediastinal subcarinal lymph nodes. That is how they have defined it. But there were some proposals that we divide this N2 based on whether single station or multiple stations are involved, because there is some difference in the prognosis if you have got multi-station N2 versus a single station N2. And I think from this year we have the TNM 9th edition. Again, I looked at it yesterday. So it basically says that N2 has to be divided into single N2 station involvement and multiple N2 station involvement. And these are the different stations. So I also put it because many people would like to look at this. Is a very good slide which basically shows what are the different stations. So my question is, how commonly are you looking at it, especially Abhishek bhai, you must be looking, as a surgeon you must be dealing with these things, you know. So how commonly, do you think this staging makes sense to you now that this N2 has been divided into two categories? And does it really change things for you?
Yeah, I think it's a very important development which had to be made as far as the management of lung cancer is concerned. And we quite often see many of the patients, they present at the time of presentation. N2 is a very commonly found lymph node station in PET scan, and I think yes, it's a very the right step in the right direction, I would say, in N2A and N2B.
So where do you draw a boundary line where I should go and what is forbidden for me?
Sorry?
Where will you draw a boundary line that, okay, this is the surgeon's domain and this is not my domain?
Yeah, so from last few years, we as a surgeons have also evolved as far as the management is concerned. And if I talk as of now, any N2, N2 is a limit for us for operating upfront. Earlier, when I was in GCRI, we had operated many patients with single station N2 for upfront surgery. But from last few years, maybe 3 or 4 years, we have started giving some sort of neoadjuvant treatment for any N2, whether it's a single station or multi-station. So I'm already sold to the fact that yes, N2 has to take neoadjuvant treatment followed by surgical management.
So who is your friend, medical oncologist or radiation oncologist? and
everyone,
where will you send that patient first?
Medical.
You can medical oncologist. Ma'am, Pooja ma'am, your take.
So I think he has no choice when you are the moderator as a medical oncologist. He would not take any pangas with me. But with an honest confession, yes, I think drawing a line is very important, because we should understand, is there going to be any role of surgery today or tomorrow? There only probably, but I think going forward in your panel, I'm sure you will show how the new adjuvant immunotherapy has taken a long way. And even for the multi-station, where Abhishek we used to previously say no, but now I think he can still say yes if there's a good response.
So I'd just like to add a point. So there's no limit to how specific you can be, because even now they are subdividing N2A. So now there's N2A1 and N2AB. So they are further dividing it to N2A1 and N2A2. That'll be a single station N2 with N1 or without N1. So there's no, specificity of how deep can you dwell into these things.
So the prognosis goes down once it becomes multi-station. That is what I could understand from this slide. But if you divide from N2, A1, 1 and that as you said, so that is difficult. I mean, what TNM is saying is divide into N2A and N2B. So again, I think based on that the staging has changed. Some patients who were stage 3A initially, because they were T1 and N2A, now they are probably going into stage 2B. And the rest of the patients probably when they were stage 3A, some of them have become stage 3B. So there is some minute difference. Again, as medical oncologists, it was always difficult for us. If a patient is sent, we will just start systemic therapy. We would not look at the staging, but I think it matters a lot to you two people as to how to go about it. So it's a highly heterogeneous group is what I think the message is, and the survival matters, survival changes if you go to a multi-station from a single station N2. Mediastinal staging. So how common is mediastinal staging? Again, Abhishek bhai, when you get early lung cancer, do you do it in all patients? Do you rely on the PET CT, or how is your approach?
So there are certain indications for invasive mediastinal staging. So if in a PET scan, we always get a PET scan for any lung cancer, okay? So I think this is the norm everywhere. So if in a PET scan, there is a clear-cut N1 station node, or if it's a tumor which is centrally located, even if it is less than 3 centimeter, these are the indications where we go for an invasive mediastinal staging, and most commonly it is EBUS nowadays. We never resort to video mediastinoscopy, so it is EBUS always. So these are the indications when I go for an invasive mediastinal staging, because you have to preoperatively stage the pathological N2 station.
So you will go for an invasive mediastinal staging?
So when there is a clear-cut N1 node in PET, or it's a big tumor, without N0, I mean more than 3 centimeter N0, you have to go.
So if the PET is clean, you would not go?
No, absolutely.
So
PET alone, for a tumor which is more than 3 centimeter, peripheral tumor 1-2 centimeter, I think PET alone is enough. But for the other indications which I just mentioned, you have to go for an invasive mediastinal staging.
PET has got a good negative predictive value.
Yeah,
so if a PET is negative, most likely you are not going to have a positive mediastinal. But if, as you said, there are some, if you have a N1 or something and you want to go in, you will definitely do that staging before you go into the surgery, and then you don't know what to do. Okay. For the radiation, ma'am, do you think, or this is the same for you as well? You would
So, to the previous question, I would like to add, I think it is not just on those bulky tumors or the N0s, but more importantly, even for the multi-station, he would like to have definitely an EBUS to confirm that whether it is a genuine multi-station or it is just a single nodal multi-station, so we can do it. As far as the radiation oncologist is concerned, of course, it matters to us, and now, as I said, the way neoadjuvant more and more molecules are available, we are also very happy to see plan the radiation volumes after seeing a good response with the neoadjuvant approach.
So if a PET scan is clearly showing N2 station, then you have to sample it. That is not a question at all. You have to prove it pathologically positive so that you can plan neoadjuvant treatment. And if it's negative, EBUS has been done properly with proper protocols, then you can definitely go ahead with a upfront surgery. Why not? T2N0, T2N1, T3N1, upfront surgery if EBUS has proven N2 to be negative.
Okay. I think especially in a country like India, we might have a false positive about 20%,
Yeah.
So we definitely need to have a EBUS before stamping it as a clear multi-station N2 plus or not.
So the diagnostic workup, sir, you can take this question. What do you do in stage 3 NSCLC?
So a PET scan would be the foremost, and then you also need to do a brain MRI. And for the surgical fitness, we'll also need a PFT, DLCO, and a cardiac workup as well. And especially we need a biopsy, and then we need to do the receptor status. I think EGFR ALK cross, PDL1 minimum. And we can do a 52 gene panel as well. But I mean, we cannot act on it, but still it will be helpful.
So you do a limited molecular testing, right?
Yes.
You do an MRI brain, especially for a limited disease.
Yes.
So it's a multidisciplinary management. I think most surgeons and the radiation oncologists, we also brainstorm at our NBT how to deal with each case individually. And I think it's these three kinds of N2 that might be sometimes the surgery is done and you get an N2 disease. Sometimes it's potentially resectable, then you have to decide what should be the management, or it might be unresectable at first glance, and then you probably go for CTRT only. So NCCN again, N2 nodes positive, CTRT is what is mentioned, and they have mentioned that selected patients might be considered for systemic therapy followed by surgery. So still I think NCCN is going with the radiation people that, okay, CTRT is going to be the first choice. Do you agree with this, ma'am?
Absolutely, but sometimes, sitting in our clinical OPD, many of the times we are very tempted to give neoadjuvant also to see the response, because that will really help us to understand which are the likely patients who are going to respond, and then subject them to a extended course of radiation therapy. So of course this is the guideline, but I am sure my all panelists will also agree with me. There are many of the times we are starting with a neoadjuvant approach rather than just going directly to a CTRT.
So again, in the olden days, many times the surgeon used to send patient for neoadjuvant chemotherapy. I don't know if anybody is getting patients for, you're a medical oncologist. Do you get requests for neoadjuvant chemotherapy?
A lot of times actually.
Do you give neoadjuvant chemotherapy or tell them that, why do you want to give neoadjuvant chemotherapy?
So actually I would not agree with the NCCN slide. I would say that there is a subgroup of patients who can actually benefit from a neoadjuvant approach, especially non-bulky, N2, single station. I think those are the candidates who are, who have a good PS, good cardiac reserve, and you can plan an upfront lobectomy. I think those are a good candidate for neoadjuvant approach. And I personally prefer a perioperative approach rather than a neoadjuvant approach in such patients, because I think there is data, but it's not a randomized trials, but these perioperative trials at about 10 to 20% of patients who had multistation N2, and they showed that they can be converted.
Okay. Yeah, Abhishek, I want to say something.
And I think especially with the advent of immunotherapy nowadays.
So this, I am talking about before immunotherapy, what used to happen actually.
So it's a totally different landscape now.
Yeah.
So other than NCCN guidelines, there are ESMO guidelines, there are Asian Thoracic Oncology Society guidelines. All of them do say that if, as Sir previously said, that if there is a single less than 3 centimeter node, and if it's non-bulky, non-adherent, you can definitely try neoadjuvant chemo followed by surgery, look at the pathological report, and then offer further treatment. So sticking to NCCN is something like it is subjective. There are different guidelines we can follow as well.
So there are guidelines they are meant to guide. So again, this was a case, hypothetical case. I think the same thing, that you had stage T3 N2B, and again it was multi-station, multi-station mediastinal nodes were positive. And I think we have discussed the nitty-gritties of this case, how we will go across this. So I think, as ma'am said, if you have multi-station N2, today's day and age, again, you would prefer to go for chemoradiation, right? So these are the different options that are put. But so which is that patient where you will think that neoadjuvant chemoimmunotherapy is you can offer that patient rather than going for chemoradiation? Abhishek bhai, what if this patient any patient comes to you with this kind of multi-station N2?
See, if it's a single station N2, there's no question you have to give.
Talking about multi-station, so our topic is about multi-station N2.
So multi-station N2, if there's a single station, there were multiple stations. One is 1.5 centimeter, say for example, another is 1 centimeter. There, I feel it's still resectable, and believe me, most of them are resectable. So these are the patients which definitely I would still plan for a neoadjuvant treatment. Yes, if there are more than 3 or 4 nodes, big 2.5, 2 centimeter, 3 centimeter nodes everywhere, then those are the patients which I would select for CTRT, definitive CTRT, followed by durvalumab, PACIFIC study. Okay. But other than that, if these are small multi-stations, just 2 or 3, limited to 2 or 3 in number, I would definitely be hopeful for a future surgery in those patients.
Okay.
So coming to that, see, if you're talking about guidelines, NCCN guidelines, multistation, N2 nodes, there's no role for surgery. Like if you stick to the guidelines, but then you have newer studies like Keynote 671 that has shown that, even with adjuvant pembrolizumab and chemotherapy followed by surgery, and then you give adjuvant therapy, it has beautiful results. So it is still not in the guidelines, but there are multiple randomized controlled trials that have shown that surgery is an option even in N2 multi-station diseases.
Yeah.
Can I just quickly add one more point?
Yeah,
I think with this beautiful neoadjuvant immunotherapies, new immunotherapies, what has really changed is Abhishek Bhai's role, where those initially he used to say inoperable. There are those borderline cases which have become resectable, number one. Number two, even as a radiation oncologist, even though seeing a NCCN saying that it's a category 1 recommendation to go for a upfront CTRT, even I would say, no, rather let it subject to a neoadjuvant approach, see what is the response, and then probably plan for radiation.
So looking at biology, I think, is also important. Many of the times, many of the cancers, we do that. When the medical oncologist gives some systemic therapy, you look at the biology, how the disease is behaving, and that probably will help you in predicting the response over a long period of time. So CTRT has benefit on the survival and reduces the relapse, and we know that there was no consolidative therapy which worked before the Pacific, and now we have the Pacific trial which has the OS advantage. But there were some issues in the Pacific. Many of these patients actually could not receive consolidative. Almost 1/3 of the patients, they had, so the condition was that if you don't get progressive disease, then you would go on to receive durvalumab. So some of these patients had progressive disease. Some of these patients had some complications because of which they were not able to put on the durvalumab. A lot of these patients were PD-L1 negative, and actually when they looked at the subset, those patients did not benefit. What about the patients who had EGFR-ALK positive? The patients were very less, so they could not conclude that whether there is any difference by adding durvalumab. Now we have a trial, we have the evidence for giving osimertinib in this setting, but the durva could not really show that there was an appreciable difference. And the question was, how many patients are able to start? Again, the same thing, when you give chemoradiation, so ma'am, how long, what is the timeline of the side effects? When do you expect the patient to be able to take the consolidation immunotherapy? What do you tell your patient?
So even if there is a good response to chemotherapy, definitely
chemoradiation, after chemoradiation, yeah.
So after chemoradiation,
when do you tell your patients to start immunotherapy?
Immunotherapy. So I think as the guidelines say, immediately after the radiation, so 6 weeks later on, we start the immunotherapy. And I think with this even approach, there is no issues of toxicities because with newer advanced radiation machines, we have been very much respecting the lung and the heart doses. So going forward, we have not seen any issues.
Okay. To the medical oncologist, have you seen more pneumonitis with this?
So yes, I mean, as you see that most of the patients do not start within the first 14 days.
Yeah.
So it usually takes them some time. So the mean time is usually 3 to 4 weeks when we start with the maintenance dose. I mean, coming on to your previous slide where you said that the PD-L1 negative patients did not achieve a good response. I think the real world data from the Pacific R study did show that the PD-L1 negative patients also had, the magnitude was lesser by about to the tune of 10%.
Again, you can see the CIs all over the place, so
yes,
maybe that is the reason.
Yeah, but trial setting and real world settings, we see that the data do not always match. But yes, I mean, all comers should get durvalumab irrespective of PD-L1 status.
So there was another trial which was followed up. So these people thought that because durva is working after CTRT, why not to start durva from CTRT? Probably there will be some sensitizing effect of immunotherapy. And you can see that there is no improvement in the PFS and the OS. So what do you have to say about this? I mean, do you feel that what could have been the reason why this happened?
So I think this is more tissue based. You are getting different results in cervix, you are getting different results in lung, but I think this is probably the new antigens that post radiation that we get, and eventually the durvalumab is acting on that. I think there are trials where SBRT is being used in early cancers, and we are trying to get more new antigens and then follow it up with the immunotherapy. So I think that is probably the context.
Okay, but I mean, I could not get the exact reason why this happened, and I think people are still thinking why this happened. But the message is that don't start durva with CTRT, always give it after CTRT. Because you see that the durva arm actually had more adverse events, there were more deaths and there were more discontinuations in the durvalumab arm. Probably I think durvalumab had some potentiation of the toxicities. So the major reasons why people died were because of infection and I think hemorrhage in that arm. So maybe durva, when you gave it with CTRT, had the triplet combination actually had something worse to do.
Maybe, I'm not very sure, but radiation might help changing the microenvironment, tumor microenvironment, and making it more susceptible for damage by these therapies. And if you see, although it's a phase 2 trial, there is a coming role of durvalumab with radiation in the SBRT format in the neoadjuvant setting. Means trying to then rather not going for the radiation as a definitive method, but then going for surgery. So I think might be the mechanism of action.
Another thing is that in lung, with this context, there's increased Tregs, and these Tregs are not letting the the PD-L1 get its full strength. So I think that is also one of the reasons that in lung we are not seeing the same compared to other sites.
Also, I think it is a phase 3, I think, but the populations probably were not balanced properly. That also some people have pointed out that maybe they were not balanced properly. That might be one of the reasons why this happened. So as you have already mentioned, there are many trials in the neoadjuvant and the perioperative. We'll just touch upon, because as you said, the data is not still mature and still it has to be put in the guidelines, but I think it is exciting for all of us. The first was the Checkmate 816, actually the easiest one to give, just 3 cycles of Nivo and chemo, and then you do this, and 24% PCR rates, excellent compared to only 2%. What is your experience with this? Have you used this protocol in any patient, sir?
So, not in India, but during my training abroad, immunotherapy is actually being friends with a medical oncologist. I'm sorry, guys. It is actually a double-edged sword, because if you start giving immunotherapy plus conventional chemo, they'll definitely refer patients to you for surgery. But after giving immunotherapy, the adhesions, the fibrosis in the lung are far worse than radiotherapy. Like there are no planes, everything is stuck, you don't know where the vessels are, it becomes a menace. So not in India, but yes, outside we have tried it, and it is a very, very, very difficult surgery.
Okay. So my first patient that I gave, so it was a stage 3B patient who had this kind of disease. I gave Nivo chemo, patient had a PCR. What happened in that patient is I had sent an NGS, so that NGS came after 3 weeks, it came as a EGFR mutation was there. So we went for the surgery, surgery had a PCR, we put that patient on adjuvant osimertinib. So one thing is that always look at this EGFR ALK status before you start this protocol. You might send a RT-PCR or something, because if you, the second patient that I started the same protocol had a ALK mutation. Again, after 21 days I got to know. That patient actually, the surgery was a R1 surgery, there was disease inside, so we put her on lorlatinib. So there is OS advantage now, and there were patients, almost almost 40% patients in both the groups did have multistation N2, and if you look at the forest plot, yes, the hazard ratio seems to be towards that side, so it seems to be significant. So all these trials, because they are heterogeneous, they have included some patients with multistation N2, and they seem to be having some advantage. Also, one of the important things I think is, as Abhishek Bhai would agree, that the extent of surgery goes down. So this is very clearly evident in the 816 that more patients underwent lobectomy and more patients were able to undergo R0 resection. So Abhishek Bhai, how common, I mean, do you find it difficult to get a R0 resection in such kind of patients when you're talking about a T3N1 type of disease?
If you talk about T3N1, it all depends on the location of the tumor.
T3N1 or T3N2?
Yeah. So our plan, either lobectomy or pneumonectomy, I think it's already decided before starting neoadjuvant treatment, and I think it's a fairly simple decision to make, Sarah, if you agree with me.
Absolutely.
So lobectomy, pneumonectomy, most of the time there is no confusion, because if the tumor is located well within a single lobe, then the plan upfront is always decided that it's going to be lobectomy or pneumonectomy. So most of the time,
I think the main problem would happen with the nodal dissection.
Yeah,
right?
so the problem occurs when the tumor is more centrally located.
Yeah.
So there are more chances of ending up in a pneumonectomy.
Yeah.
So, but if it is little further away from the central zone, then I think the decision is fairly straightforward. We I think never face such problems.
So I'd just like to add over here that so at certain times when we think of a pneumonectomy and we give the patient some kind of adjuvant therapy, if the disease regresses, there's a very high chance that we might think of doing a sleeve lobectomy. So that completely changes the patient's quality of life after the surgery. Like pneumonectomy and then going for a sleeve lobectomy, that will be a completely game changer for the patient.
Yeah. So I think same trials, Keynote 6-7 used Pembro in the same setting. Also, almost 40% of patients had N2 disease, and in the forest plot we can see that these patients also had a statistically significant benefit. Same for Nivo plus the perioperative nivolumab, that is the Checkmate 770, where also you see that N2 patient, almost 13% patients, 13, almost 10 to 15% patients were multistation, and they did benefit by adding this perioperative immunotherapy. Same for the Oncogene trial. So what I am trying to say is that all these trials, they have basically shown that there is some benefit, and the hazard ratio is on this side, 0.4 to 0.6. So in today's day and age, I think it is worthwhile to go for this strategy and see what the response is. Conversion surgery, again there was a study here which basically showed that a lot of these patients did get either a complete pathological response or a major pathological response, that is more than 90% response. So I think, Abhishek bhai, do you find difficulties in doing a surgery once you have given chemotherapy and immunotherapy?
Yeah, see, I have not had much experience with this combination pre-operatively.
Yeah.
So I operated only, I think, twice or thrice for a patient with chemo-immuno. And as I would agree with Sarav that there was some sort of fibrosis while doing the dissection, but it was not that difficult. So not much experience, but the patient showed excellent response after chemo-immuno.
Okay.
Yeah.
So then this is a gray zone, what I want to say, and this is potentially resectable maybe. So looking at the biology, looking at the neoadjuvant strategy, and then seeing what the response is, we can decide what should be done. And another important thing that we often, we should discuss that in the neoadjuvant setting when we give immunotherapy, PD-L1 does not matter. So we have seen this across the board that if we give immuno in the neoadjuvant setting, probably the immune system being intact or not undisturbed, probably the PD-L1 is not important. Here also we can see that those patients who were PD-L1 negative, they also did well, the PFS was significant. And Durva, as I said, PD-L1 negative, some problems are there. EMA actually has not approved it in PD-L1 less than 1%. Surgical difficulty, as sir said, there are some problems, but I think as we see more and more patients, so we learn because we have given this therapy in other cancers as well. So I think surgeons will evolve, they would learn how to deal with this.
I think finances is a very big issue in our country. Nivo cost around 7 to 8 lakhs a year. I think so that is the problem which we face most of the time.
So they don't
in
have money for
convincing our
surgery.
patients. Yeah.
Sir, we were facing the same thing.
I would want to
doing
give
the surgery and sending the patient.
See, after the results of Checkmate, I would want to give Nivo plus chemo. Definitely, why not? But practicality is also an issue.
This is another survey actually. They looked at the bulkiness. They said that if it is bulky, we would go for CTRT. If it is non-bulky, then probably surgery is a better option. So I think it is a heterogeneous subset, has to be discussed, whether it is bulky, multistation, whatever different terms we want to use, but it has to be discussed on a case-to-case basis. And sorry, Amul sir had put this tweet and what to do in this kind of, if you have a T2 N2 disease, NSCLC, what will you do? So most of the people actually now say that go for a neoadjuvant approach, and that is what most of those people. So I think, yes, CTRT has its place, but do not forget us as well. So neoadjuvant strategy should be discussed. Thank you.
Thank you.